The Self-Care Learning and Discovery Series is back, and it's bigger and bolder than ever. This is the premier self-care event of the year, bringing together self-care enthusiasts of all backgrounds and disciplines from around the world. The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. We also know that self-care means different things to different people. What does self-care mean to you? You'll have ample opportunity to reflect on this question during the Discovery Series, with more than 20 interactive virtual sessions organized by self-care experts worldwide. The Discovery Series will elevate cutting-edge research, programming, and advocacy insights across a wide variety of self-care topics, and we encourage you to attend as many sessions as possible, especially on topics that may be new to you. The Self-Care Learning and Discovery Series, a core activity of the Self-Care Trailblazer Group, is organized by the White Ribbon Alliance in partnership with co-sponsor organizations and esteemed steering committee members. We also want to thank all our session organizers and presenters who have voluntarily dedicated their time to curate this event with us. We are pleased to share that every session will offer live, simultaneous interpretation in French, Spanish, and English. To access the interpretation, simply navigate to your meeting controls located at the bottom of your screen. Click on the globe icon labeled Interpretation and select the language you'd like to hear. Joining from your phone, tap on the ellipses to find the interpretation feature and then select your language. Please note, you can switch languages at any time throughout the presentation. The session is now about to begin. Don't forget, whether you're working to influence policies or programs, advance universal health coverage, or improve your own self-care, we hope that you will take the learnings from today's discussion and apply it to your own work. To that end, we invite you to continue the conversation and take action with us by becoming a member of the Self-Care Trailblazer Group. So get curious, jump in, and share your ideas and insights with us. We look forward to advancing self-care together.
Hi, everyone. We are happy to have you all here, and welcome to today's session of Self-Care and Learning and Discovery Series, which is utilizing private pharmacies for self-care products and services. I am Alamsha Tayalio. I'm based in Ethiopia. I'm a pharmacist with more than 15 years of experience in the pharmaceutical sector. I have worked in different community and private pharmacies, including hospital pharmacies, as a technical head, ensuring the quality of pharmacy service and supply chain consistency. Especially while I was working in hospital pharmacies, I used to counsel and make sure that clients with HIV are adhering to their medications. And I have also worked with medicine and medical devices importers as a technical manager, assuring the quality of products imported through the registration of the products, implementation of good distribution and storage practices till the products reach retailers. I will be the moderator of this panel, and I love being the moderator of this panel. I'm gonna launch a Zoom poll just to know who's in the room. The Zoom questions are just to know who is a pharmacist, whether you are a pharmacist or not, and where you are coming from, like your affiliation. Are you from government, donor, INGO, or NGOs, or academia, professional associations, and others? On today's panel, we will look how to determine whether the private pharmacies are more likely to increase access to self-care initiatives, the potential of and lessons learned in working with pharmacies, and a comparison between private pharmacies' clientele demographic and outcomes, and those accessing self-care in public sector settings. As you guys know, pharmacies are more accessible than public sector settings. We can get them everywhere in our surroundings. So there is a huge potential if we can use them to increase access for self-care products and services. Like, for example, there are lots of products like pregnancy test strips, home pregnancy test strips, emergency contraceptives, glucometers, just to check your glucose level, blood glucose level, and medical abortion tabs. Among these, our today's session will mainly focus on products for PrEP for HIV in private pharmacies, making them accessible for clients. This PrEP stands for pre-exposure prophylaxis for HIV. We're going to have 3 speakers today. Just to introduce them, the first speaker is Rusha Hess, who is based in US. Rusha is the principal of a consulting firm named PropelVet, where she supports change makers working at intersection of the private sector and social impact in diverse global contexts. She leads the health portfolio for PropelVet and provides cross-cutting expertise on gender and behavior change. Rusha brings more than 20 years of implementing, designing, and managing sexually related health and rights and reproductive, maternal, neonate, and child health global health projects in Asia, Africa, Latin America, and the Pacific. Welcome, Rusha. The second speaker is going to be Dr. Tabitha Keriti, who's based in Kenya. She is a pharmacist by profession and currently working as a research pharmacist at Partners in Health and Research Development. She has experience of working in clinical trials and is now coordinating an implementation science project with a focus on differentiated service delivery models for HIV prevention to expand reach to the community. Welcome back. Welcome, Tabitha. And our third speaker will be Jocelyn Newcomb, who is based in Vietnam. Jocelyn currently oversees public health programs and research targeting more than 260,000 pharmacy professionals through the largest pharmacy-focused digital platform in Southeast Asia, SwipeRx. She serves on USAID Self-Care Technical Expert Group, and Jocelyn brings 28 years of experience in learning the design, implementation, evaluation of pharmacy-focused public health programs in more than a dozen emerging markets across Africa and Asia. Since joining SwipeRx in 2020, Jocelyn has built partnerships and market-shaping initiatives assisted by technology to improve pharmacy access to quality-assured self-tests for COVID-19 and HIV. Welcome, Jocelyn. Before going to the presentations, there are a few rules for the session. Make sure you are muted throughout the session. This is just to avoid any interruption. If you guys have questions, you can drop your questions on the chat box. And we will have 5 minutes at the end of each presentation just to entertain 1 or 2 questions. Otherwise, the rest of the questions will be entertained on the final Q&A session. Please write the name of the presenters whom you are asking your questions for. That will be supported. And at the end of the session, we will have a feedback collecting link. So please be genuine just to give your feedbacks on the link. Inviting the presenters, I will go to the first speaker, Rusha Hess. Rusha, over to you.
Great, thank you so much, Alamshet. So as Alamshet mentioned, I'm Risha Hess. I work for PropelVet. And I'm going to be talking today about a project that we did that was funded by the Bill and Melinda Gates Foundation that was looking at whether pharmacies as a channel in Africa would greatly increase access to PrEP. And, you know, obviously there's going to be an investment with getting a new channel open. And so is it worth it? And if so, where to start? We did this project with Catalyst Global, and you can see at the bottom of the slide, several independent consulting agencies, West East Alliance, Business Academy and Practice from Nigeria and Cameroon, respectively. So the first task was to figure out which countries we were even going to look at. And we used 3 criteria to figure that out: the absolute number of key populations, including adolescent girls and young women and men, as well as female sex workers, people who inject drugs, and MSM populations, the relative risk of transmission, and whether PrEP was already in the country. And using those criteria, we started with these 18 listed on the slide. It was a very high level assessment. This was, again, just to make that first decision, is it worth going further and learning more about pharmacies and where to start? So we were looking at very broad information about the types of pharmacies and how they're set up in each country, customer demographics, trends, challenges, and opportunities. The limitations of this are quite large because it was so high level. So we weren't able to get all the data that exists for all countries. In particular, margins were not something most informants were willing to talk about. And in terms of the literature review, the customer behavior literature was really thin. And so we weren't able to make comparisons between countries. So before we get started, I wanted to launch a poll and figure out, are you more interested in learning about the findings of this study, or are you more interested in learning about the methodology of this study and how to do it yourself, or both equally? And I can focus on one of those or the other. I will do both. I'll just do shorter for the one you're less interested in. I'm watching the results come in, and it's really even. All right, I think I have to call it a draw. So most of you want both, and then a slight larger percent want the results. So let me start with the results. The first thing to say is that there is really good research on this, on PrEP in pharmacies in particular, and what we found did reiterate that. So from most countries provide PrEP through their governments and through their existing ART mechanisms, and studies have found barriers to people wanting to adopt that include lack of privacy, stigma about going to an HIV clinic since they are not HIV positive, time spent, and relatedly understaffing. And pharmacies are really well placed to answer a lot of those challenges. Again, those aren't barriers for everyone, they're barriers for some. And so for those some, pharmacies do consistently provide reach, convenience, and a less stigmatizing environment. There are several ongoing programs and pilots. Tabitha is going to talk in depth about one just after me, so I will leave that to her, but the results have so far been good. But there are concerns. And so it's not that you can drop the medication into the private sector and expect it to roll out easily. There will be training involved. There are potentially unintended consequences with taking people out of the public sector. And there are quality concerns around counseling, history taking, and the quality of drugs. At the broadest level, this is what the pharmacies provide in each of these countries. So we have, in all countries, pharmacies provide both branded and generic medications, over-the-counter medications, and do services such as blood pressure. In 13 countries, they are providing HIV tests through pharmacies, and there's one pilot in addition. In only 7 countries, they are allowed to do injections. You'll see some asterisks here. In 3 countries, nurses are allowed to do injections, and nurses are working in pharmacies. So there may be an opening there. And then actually in 10 countries, ART is already being distributed through pharmacies. In most cases, this is refills, not pharmacist initiated. The trends that we saw, again, nothing applies to all of the countries. So these are generalizations for most of the countries. The pharmaceutical sector is underregulated as compared to public sector and even private clinics, but there are efforts underway to strengthen that regulation. In the last few years in particular, this unreliable supply of medications in the public sector is driving more and more people to private pharmacies. And as a result, we're seeing huge growth in private pharmacies in most countries. the number of trained pharmacists and licensed pharmacists is not keeping up with that growth, and so we're facing a shortage there. Tier 2 outlets are really important. This is our language, but what we mean by that is sort of drug shops, PPMVs, ADOs. They have different names in different countries, but the smaller shops that definitely have over-the-counter, often don't have prescription legally, but may or may not have them anyway, and are the first stop in many countries for people's health care. And so countries are recognizing how important these are and starting to bring them into the regulation and saying, you can provide these specific pharmaceuticals with this training and with this quality control. And so a list here on the right is of those countries who have brought them in. And this is a really high potential outlet because there's so many of them in these countries. Pharmacies tend to be urban. There's a lot of innovation going on in this sector. So the e-pharmacies, delivery models, mobile payments. More countries are moving into clinical pharmacy. So recognizing that pharmacists do more than just dispense drugs, but also do counseling and prevention care, et cetera. And then really importantly, the private and public sector supply chains in most countries, again, not all, are quite separate. And so just because there's PrEP in the country that was brought in through the public sector, it's not going to be that easy to get it over to the private sector because those mechanisms don't exist. So it either will take time or you'll have to create another parallel private sector supply chain. The opportunities are great. Key pops go to the pharmacies. The top customer segment is often adolescent girls and young women and young men. Stigma is a big concern, particularly for the most marginalized groups. So this table to the right shows the percentage of people within certain groups that avoid healthcare due to that stigma. We have things almost 50% of female sex workers in Malawi, 64% of people who inject drugs in Uganda are avoiding healthcare. So providing them something that is less stigmatizing could be crucial. Pharmacists are interested in being involved, and there's a few ways to accelerate how to get into markets. Wholesalers are one, where there might be just one or two in a country serving everyone. They can not only get product out to all the pharmacies nationally, but also education and training. And Jocelyn at the third presentation is going to talk about another such accelerator. And of course, there's challenges. So many countries have not integrated private pharmacies into public health, and particularly HIV, and there's growing pains with that, particularly around systems integration, data integration, payments. Everyone sort of gets stuck on the financial incentives. If it's free to the consumer, which it is through pharmacies in some countries, how do you incentivize all the players on the supply chain? If it's not free and it's fully commercial, are the prices too high for people to afford? But there is a lot of work being done in this space. And there is resistance. So the resistance often comes from other healthcare provider cadres, doctors in particular. This might show up as government bodies dragging their feet on opening up the possibility of private pharmacies providing these. In South Africa, it resulted in a lawsuit, which was recently decided in favor of allowing pharmacist-initiated ART. And the actual results of the study showed that we had 3 first, second, and third look countries. These groups all had more pharmacies than the potential government ARTs and clinics. So the fourth look countries are places where there actually aren't enough pharmacies to make any additionality. So that's DRC, Lesotho, and Malawi. If tier 2 was available in Malawi, they would. The rest of the countries all have more pharmacies than ART centers, but we want to look about how many people you could reach. So we can reach over 1.5 million people in Nigeria, South Africa, and Tanzania. So that's obviously the starting point. The third look countries, for instance, get under 500,000. And so that might not be worth the cost and investment and time of opening up this new channel. To go briefly through the methodology, I've actually sort of talked through it, but you need to figure out where you're going to start and what those criteria are. The comparator for access is really quite key. So we used public sectors for ART because that's where PrEP is being scaled in most countries. but we also had a database of all of the locations of those clinics. And so finding something that is the comparison and you do have data on location it can be really difficult. Once we made those decisions, we started our desk research. And I do want to flag that many countries have their pharmacy lists, including locations, available online. So it's definitely worth looking at the Ministry of Health and Pharmaceutical Association's websites. We then looked at filling the gaps through key informant interviews. So we typically talk to a pharmacist, a wholesaler distributor, and someone with a national view at the Ministry of Health or the Professional Pharmacists Association. Then we ran site comparisons and calculated potential reach, and I'll focus on those two in a second. I just want to back up and say defining accessibility and having a shared understanding was key for us. We use the Levinesque definition, which says it has acceptability and availability. And so acceptability is, I want to use this. There's not much stigma. I'm happy to go here. Availability means it's physically convenient, but also the hours are convenient. The days it's open are convenient. The waiting times are convenient. And so on both of these, pharmacies do really well. Even if there's an ART center next door, we may find that there's more availability for the pharmacy next to it because of those longer hours and less waiting time. I'm going to skip the green light there. This is an example from Tanzania of how this looked. So we got regional data for all of them. ADOS is their tier 2 in Tanzania. And you can see here that we found that overall there are more ART sites than pharmacies in the country, but the pharmacies are concentrated where the population is. And so they can increase access in those population centers. ADOS would be a game changer. That would exponentially increase reach. And then we want to get the potential reach total. And so we looked at the number of target audience. I'm just showing you adolescent girls and young women and men. We also did this for the other key pops. The percent of, taking out those who are already HIV positive, because this is a prevention medication, looking at those most at risk, we used data that we could get across countries, which was 2+ partners. And so, for instance, in Tanzania, we had a total possible reach of 4.3. We then reduced it to look at, which were first look, second look, by urban, because as you saw, the pharmacies are so concentrated in urban. So that's a very brief overview of how you might do this for your own setting. And that's it from me. I'll open it up to Alamshat for questions.
Thanks, Risha. Let's see if there are questions. There is one question. It says, is PropelVet's report on this work publicly accessible?
That's a great question. It is. We are happy to share it. It is not put somewhere that is publicly accessible. So trying to think the best way to do this. You're welcome to email me. I think my information is in there, or I can figure out a way to get it at the end of this presentation to get people who are very interested.
Okay. Is there any question from the audience? Okay, if there is no, let's pass to the next presenter. Okay, okay, there is one question, Ruth. In general, what is the range of RH products that are available at pharmacies?
I mean, it does quite differ, and you're pressing my memory. I might not be able to remember details country to country, but I think we generally see a lot of sort of self-care contraception, so EC, condoms, often pills as well. We saw young men coming in a lot for sexual enhancement products. And then, of course, menstrual health. If there's something specific, feel free to add a follow-on comment, and I can think about what we found for that product.
Okay, thank you. If there is no more question, let's pass to our second presenter, Dr. Tabita. Dr. Tabita, over to you.
Thank you, Almashat. My name is Dr. Tabitha Kareithi, and I will be presenting on behalf of the PharmPrep studies being conducted here in Kenya on the potential advantages of PrEP service delivery at private sector pharmacies versus public sector clinics. Next slide. In Kenya and in Africa in large, the HIV incidence remains high and barriers to PrEP access remain. Some of these barriers include stigma, limited hours of operation, long wait times, and travel distance. In a bid to combat this, the Ministry of Health created a framework which would look at differentiated models of PrEP delivery and identified pharmacies as a target delivery point. And so my presentation will also be building on to Risha's previous presentation. Next slide. Pharmacies have shown the potential for PrEP delivery because in low and middle income countries, roughly 50% of individuals seek their health services from pharmacies first. Pharmacies can also address urgent care needs such as STI treatment and preventive care needs such as blood pressure testing. We also noted that some of the services that are offered at pharmacies are offered for free at public clinics like contraception. And in Kenya, there are more than 5,000 licensed pharmacies, which are overseen by a regulatory board requiring annual license renewal and continuing professional development requirements. Next slide. In light of this, we have been conducting an implementation research related to developing and testing a model of pharmacy-delivered PrEP services, which began with a formative research where we collected information about some of the barriers to this intervention, pilot studies, which I will be speaking about today, and a cluster randomized control trial, which could tell us more about the scalability of this intervention. Next slide. In January 2020, during a stakeholder meeting, which was attended by regulatory bodies, national policy makers, as well as various stakeholders, we developed a care pathway of delivery of PrEP services at private pharmacies. This care pathway was based off a prescribing checklist, which is currently being used in a US model to deliver PrEP at pharmacies. The prescribing checklist was created in order to assess clients who would be eligible for PrEP initiation and would have no contraindications. Some of the core components included behavioral risk assessment, medical safety assessment, HIV testing, and dispensing of these drugs. And all this was done with consultation with a remote clinician and referral to public facilities when needed. Next slide. So we have since tested this care pathway in 2 pilot designs, which I will speak about in the next slide. For pharmacies to participate in this pilot design, they needed to have a private room and a licensed full-time pharmacist or pharmaceutical technologist. Clients would be eligible if they were above the age of 18 and met the criteria on the prescribing checklist. Some of the recruitment measures we used included posters that were put up at the pharmacies, word-of-mouth referral from other clients, and pharmacy providers would also reach out to individuals who came to purchase sexual and reproductive health products. The commodities used during these pilot studies, these are the drugs and the HIV self-tests, were provided by the Ministry of Health free of charge. And the outcomes that we looked at included PrEP initiation, PrEP continuation, and some implementation outcomes such as acceptability, cost, and safety assessment. And these studies were done in Kisumu and Thika, as shown in the map to the right. Next slide. To date, we have completed 2 pilot studies, which we can see here in this table. On the right, we had our original pilot study, which ran for 12 months and was conducted in 4 pharmacies. In these pharmacies, oral PrEP was provided, and the providers used oral fluid HIV self-test kits. Clients had to be above the age of 18 and meet the eligibility criteria on the prescribing checklist. And in this study, clients paid a fee of 300 shillings in order to get the service. We then extended the original pilot study to 12 pharmacies, and it ran for a duration of 6 months, where we offered oral PrEP, PEP, and STI testing in some pharmacies. And here, the providers used blood-based HIV self-test kits, and there was no cost to get adopting these services at the pharmacies. Next slide. This is just a slide showing us some of the pharmacies and pharmacy providers that participated in the pilot studies. Next slide. I would now like to launch a poll where I would like to find out. So among those listening here today, what population would you say most accessed pharmacy-delivered PrEP during our pilot studies? Do you think it was serodiscordant couples, married men and women, unmarried men and women, individuals who identify as key population, partners of unknown HIV status, those under the age of 25, or those over the age of 25, even as we move on to our results section? 20 more seconds and we can close the poll. So I can see most of us have chosen individuals below the age of 25 and partners of unknown HIV status and unmarried men and women. So I bet you will be interested to see our results. Some of the key insights we gathered from our pilot studies were that oral PrEP initiation was high amongst PrEP eligible clients. Next slide. As we can see from this flowchart, out of the 575 clients who were screened in the original pilot study, 287 initiated PrEP. This represented a 58% PrEP initiation rate. And of interest, we saw that more than 90% of those who initiated PrEP had never used PrEP before. And in comparison, during our extension study, where we screened 963 clients, we had 661 who initiated PrEP, which represented a 95% initiation rate. And also in this study, more than 80% of the individuals who initiated PrEP had never used PrEP before. Next slide. We also learned that private pharmacies would reach populations at HIV risk, and these individuals would differ from those reached at public clinics. Next slide. So as we can see from this table, the most common group of people that initiated PrEP at private pharmacies, we had roughly 50% who were male, 50% who were below the age of 25, and 3/4 of the individuals who initiated PrEP were unmarried. We also saw that most of the common HIV risk behaviors were inconsistent condom use, partners of unknown HIV status, and individuals with multiple sex partners. In comparison to some of the studies we have done in public clinics, where we provided PrEP through HIV clinics, MCH clinics, which are mother-child health clinics, and family planning clinics, in these clinics, we saw that individuals with partners living with HIV initiated PrEP more in these clinics. Next slide. We also saw that when it comes to PrEP continuation, the rates were high and were almost comparable to those observed at public health clinics. Next slide. During our original pilot study, any continuation was rated at 55%, and during the extension study, we had 72% continuation. And when we talk about continuation, we mean continuation that was done within the window of 7 days, or those that stopped and restarted PrEP. And we also saw that men over the age of 25 years had the best continuation rate. Next slide. And in comparison to continuation rates observed at public clinics, the graph below shows continuation rates at our pilot studies, which are the bars in blue, and continuation rates at the implementation projects we conducted in public clinics, which are the other bars in purple. And as we can see, continuation rates in private pharmacies and in public clinics were almost the same, if not higher, than those observed at public clinics. Next slide. Finally, we also learned that pharmacy PrEP was acceptable not only to clients who received these services, but also to providers who delivered these services. Next slide. These are just some of the perspectives we gathered from the clients and the pharmacy providers, with some clients stating that they liked it because it was close to where they live and there was privacy, and others stating that it was easier to get PrEP there. From the pharmacy providers' perspectives, they liked the idea of delivering PrEP and PEP because they were able to reach more clients, and they also stated that it makes the community they live near know more about the preventive measures to prevent the spread of HIV. Next slide. We are now implementing a cluster randomized control trial, which will provide insights into the cost of delivering PrEP at pharmacies, as Risha spoke about in her presentation, as well as whether there is any value in delivering PrEP in pharmacies or maintaining the current standard of care. This study is being implemented in 60 pharmacies, and the pharmacies are divided into 4 arms. In the first arm, the clients receive the service at a fee. In the second arm, the clients receive the service for free. However, the study covers the cost of delivering this service. In the third arm, we have introduced a new cadre, the HIV testing counselors, who assist the pharmacy providers in testing, in HIV testing the clients who come. And in the fourth arm, which is our control arm, we are maintaining the standard of care where clients are referred to the public facilities for free in order to initiate PrEP. This study launched in 2023 in June this year, and will tell us more about the scalability of this intervention. Next slide. In summary, we learned that PrEP is not having maximal impact on HIV incidence, despite us knowing that it is effective, and this could be because it is not easily accessible to all in need. Additionally, private pharmacies are a promising delivery channel and could help Kenya sustain its HIV response. The pilot studies we conducted suggested that the model is highly feasible, is effective for reaching a different subset of populations, as we have seen in our previous studies, saves time, and is cost effective. It also neutralizes stigma that comes with accessing HIV prevention drugs, because pharmacies provide a variety of services and individuals could go to pharmacies for any reason. Finally, we can say that delivery of PrEP through pharmacies not only empowers individuals to get information from accessible sources, but also enhances personal agency. Thank you. So any questions?
Thank you, Dr. Rita, for your deep research and insight on PrEP in Kenya. Let's see if we have few questions. Of course, there are, but we can entertain 1 or 2. The first question is, Dr. Tabitha, any insight on why you had many more clients with reactive HIV tests in the extension model versus the original model? Did the wider array of services have anything to do with it?
Yes, I believe that the wider array of services we offered would have led to why we had more individuals with reactive tests. Additionally, we did offer PEP during the extension services, and we know that lack of adherence to PEP could lead to a reactive HIV test, and so that could have been the reason why.
Okay, we can entertain 1 more question. What is the potential for pharmacists to provide injectable PrEP? And what is the regulatory position? Are there lessons learned from the MPA-SC that might apply?
Thank you for that question. That's actually a very good question, and it's something that we are also currently looking into. So pharmacies do have the potential to provide injectable PrEP, and this is something that we can gather from their provision of contraceptive injections to individuals who come for them at the pharmacies. Currently in Kenya, the injectable PrEP, which is cabotegravir, has not yet been approved for use, and therefore we would have to wait until it has been approved for use in order to know what regulatory barriers there might be to pharmacies providing PrEP, providing injectable PrEP. But they do have the private rooms and they can be trained to provide these injections. And so we do believe that pharmacies can provide injectable PrEP. As for the lessons from DMPA subcutaneous, I believe that even as we conduct our implementation study looking at delivery of injectable PrEP to pharmacies, we will be able to borrow some lessons from there and see how that might apply to injectable PrEP.
Okay, thank you, Dr. Tabitha. We will entertain the rest of the questions at the end of the presentations. I will let the third speaker, Jocelyn Newcomb. Over to you, Jocelyn.
Thank you so much. Bear with me while I share screen. It says one participant can share at a time. Not sure yes, should work. Great. So thank you all so much. I'm very pleased to be with you today to share the experience from SwiperX. I'm going to talk a little bit about how we're leveraging technology and our digital platform, which serves pharmacy professionals across 6 markets in Southeast Asia to scale self-care. A little bit of background about the challenge that we're solving at SwiperX. I think most of you joining today's session are pharmacy champions to some extent, and you therefore are very well aware of the fact that pharmacy professionals, including but not limited to pharmacists, are frontline health providers, right? We know from research that individuals in a number of low and middle income countries visit a pharmacy 12 times more than they visit their primary care provider at a health facility. And this is because pharmacies are extremely accessible, right? I live and work in Vietnam, where there is a pharmacy every 50 meters. They are open when health facilities are closed, including early morning, late evening, weekend hours. They are perceived as offering more streamlined and efficient services. And they are, in many cases, particularly when we're speaking about community pharmacists and drug shop operators, they are trusted neighborhood providers of primary care. And so they offer a lot of advantages, as all of us know. However, the challenge is that the fragmented nature of the pharmacy channel makes it very difficult for most partners working in the global health space and industry partners to scale pharmacy engagement. And that's what our network and our technology is working to address. So through SwiperX, we have built the largest pharmacy-focused multifunctional network, which has been used to date by almost 270,000 users. Majority of our users are women pharmacists, and the majority of our users are working at retail pharmacies, but we are open to any pharmacy or drug shop professional. And through our free access platform, our users are able to benefit from a number of different pharmacy-specific benefits and functions. And I'll walk through some of these in later slides, so I won't go into more detail at the moment, but I do want to emphasize that all of our content is pharmacy-specific, and all of our within the platform, we're offering a range of benefits and functions, which has been really critical to our success, as has been our partnerships with professional associations. And as you can see in the slide, we work very closely with all of the pharmacy and drug shop professional associations across all 6 markets where we work. And these partnerships have been critical to ensuring that our content is consistent with national guidelines, including what is allowed by the National Pharmacy Scope and Standards of Practice, and partnering with associations to ensure that our content and our digital professional education and other quality improvement tools can be linked to accreditation units, which can be used to meet the relicensing requirements. So our partnerships have been critical. And as a result of the multiple benefits that we offer to our users free of charge, as well as our partnerships with the professional associations as well as our industry and global health partners, we have achieved dramatic coverage in a relatively short time. We launched in 2017. So in about 6 years, we are now engaging up to 70% of all registered pharmacists in the markets where we work. And you can see the market-specific coverage in this slide. The different aspects of our model are shown here. And in short, when we're thinking about self-care, I'm going to try to relate the different benefits that we offer to our partners in the self-care framework. And so if we just go left to right, we do a lot of research through our platform, as you can imagine. With almost 270,000 users, it's very efficient for us to collect insights from the pharmacy channel for our clients and partners. And so if a partner wants to launch a new self-care product, if the ministry wants to inform their national self-care guideline with data from the pharmacy channel, it's very easy for us to conduct a digital survey. We can segment our surveys. So if partners want to collect data from users who were involved in pharmacy procurement practices, or if they want to collect data from pharmacy professionals who are involved in serving clients, right, dispensing product and providing counseling, we can segment our research that way. We also do a lot of qualitative research through our platform. So we are a major generator of insights related to self-care and other priority community health topics. We also deploy digital, highly interactive behavior change campaigns. We use a news feed, which is integrated into the app. And we also have social media channels corresponding in every market where we work. We are the largest provider of digital professional education and other quality improvement tools. So some of the challenges that Risha and Tabitha alluded to are being addressed through our platform, and I'll share a few examples of how we're doing that in one of the case studies that I'm going to share later in my presentation. We also develop a customized e-tools, and what you can see on the screen here is an e-referral tool, which has been developed with support from USAID and the Global Fund in Cambodia, and it's integrated so that it's designed to help pharmacy professionals, to make it easier for pharmacy professionals to screen and refer clients who need care that cannot be exclusively provided at a pharmacy for family planning, HIV and other STIs, and also TB. And last but not least, we're transforming the pharmacy supply chain with our technology. In Indonesia, we have an e-commerce function that's integrated into our app, and we are helping more than 25% of all registered retail pharmacies across Indonesia procure quality products for the best price and delivery terms through our platform. Outside of Indonesia, we're using a slightly different model whereby we help connect our users, so retail pharmacy professionals, with commercial suppliers of quality assured products. And that model is part of the case studies that I'm going to share with you. So in short, we're leveraging those different aspects of our model to help partners do two main things. One is to build capacity through the pharmacy channel to support self-care and other community health priorities. And the second is to strengthen the supply chain and improve pharmacy access to quality assured, affordable products. So the first case study that I'm going to share is from Cambodia, and I'm going to just talk briefly about how we are collaborating with the National HIV Program, the Global Fund, and 3 different commercial manufacturers and distributors of quality assured registered self-tests for HIV. The problem that we're solving together is that pharmacy and drug shop operators are a major source of HIV prevention products and advice for key populations. So they are already serving the community, particularly in the urban areas of Cambodia. But most of the innovation, including PrEP and self-test innovation, is being driven through public or civil society channels. And the pharmacy network and the channel as a whole has been left out of these innovations, which is neither good for key populations because choice is always a good thing. And as one of our participants mentioned in the chat, and it's really important to coordinate that public and private distribution, so that key populations have options, and so that the fully subsidized products, including self-care products, including HIV self-testing, can be targeted to key populations who need fully subsidized or partially subsidized product, but so that key populations who can't afford to pay commercial prices for these products have access through pharmacies. So how did we address those challenges? We're motivating HIV self-test stocking and merchandising, as well as dispensing and counseling practices, using a number of components of our model. And what I wanted to emphasize here is that we're emphasizing the benefits not only for clients, because as all of us as self-care advocates recognize, there are many reasons why self-care, including self-testing, makes sense for communities and individuals, but it's also important when we're looking at the pharmacy channel to think about how to motivate the trade and how to frame the advantages in terms that will resonate with pharmacy professionals, particularly those who are involved in stocking and dispensing the products that we want to crowd into this channel. The results that were achieved through our technology, you can see, we want to emphasize a few things here. Firstly, we delivered a Ministry of Health approved and Pharmacy Council accredited digital education webinar. And through that webinar, more than 1,000 pharmacists across the country were educated about HIV self-testing in less than 2 months. So remarkable scale with speed and far less cost than would have been required to achieve those results using offline methods. We also scaled access to 3 different locally approved self-test products, and we're doing that in partnership with commercial distributors. So we're not responsible for delivering. It's not a social marketing initiative. We're just connecting our users with existing commercial suppliers to facilitate sales and encourage stocking the right self-tests. And through these achievements, the project has contributed significantly to case finding. You can see not only HIV and other STIs that have been treated as a result, but also TB cases and HIV negative clients who have started PrEP in just the first 8 months. I won't go through the summary of what works in this slide because I know we're running short on time. So moving to the second case study, this is a study that falls a bit outside of this panel's focus on PrEP and other HIV self-care innovations, because we really want to talk a little bit more about how we're leveraging our technology to improve access to self-test, quality assured self-test beyond the HIV sector. And the challenge that we were solving and continue to solve in this case study is that whereas during the pandemic, a number of rapid antigen tests for COVID-19 were available through the pharmacy channel in Vietnam, but also throughout Southeast Asia and probably in every country where all of us were living at the time, it was very difficult for pharmacy professionals and their clients to understand which of these tests were quality assured, which were specifically designed for self-testing as opposed to provider assisted or provider led testing. And so we leveraged our technology and designed rapid interactive digital campaigns, as well as an activation model with commercial suppliers of 2 quality assured nasal self-tests. So just differentiating them from the nasopharyngeal tests and differentiating them from many other rapid antigen tests, which were locally registered but did not meet the quality assurance guidelines for self-testing globally. And you can see that in less than 10 months, more than 17,000 quality assured self-tests were procured by 339 retail pharmacies linked to our platform in 3 different parts of the country. 92% of pharmacies sampled through a digital survey conducted at the end of the activation phase were found stocking the right test, quality assured tests, whereas only 29% of the non-SwiperX trained and engaged pharmacies were found to stock the right tests. I just want to emphasize that negotiations with local suppliers to secure discounts, these were commercially negotiated, so there was no subsidy involved. no donor subsidy provided, but making sure that continuous negotiations occur to help pharmacy professionals access the best products for self-care at the best prices is highly recommended. And then leveraging a very far-reaching and interactive digital network like SwiperX to nudge improved stocking, merchandising, dispensing, and counseling practices, but also combining that with targeted activation. Would be happy to provide more information to any of you who are interested. And before we transition to more Q&A, I just want to take a moment to thank all of the partners, public sector and commercial, who contributed to the case study shared today. Thank you so much.
Thank you, Jocelyn, for your sharing this amazing platform, which really supports pharmacists to equip with knowledge and information, and enable them to give quality services for their clients. Thank you very much. Let's see if there are few questions for you before we jump to the bigger Q&A session. Okay, the first question is, do any of your tools link to national health information systems? Any are linked to data from our digital tools?
That's a great question. And the first case study that we shared from Cambodia is linked to the National HIV Program's client tracking system. So we are connecting with an online client booking system that the National HIV Program operates. And because of those linkages, we're able to help the national program track clients from pharmacy referral to the health facility. So we're able to compare on a monthly basis, look at that trajectory, and also track loss to follow up, right? So it's wonderful when national MIS systems are digitized, and it's wonderful when we can connect with them, because it does enable them to utilize information, data from the pharmacy channel and link it with the data that they are reviewing regularly from health facilities. Unfortunately, that's not the case for every program in every ministry in every country yet, but I know that there's a lot of progress being made, and at the company at SwiperX, we're very excited to be part of facilitating that end-to-end client tracking.
Okay, thank you. There's one more question. Do pharmacists pay for this service? If not, who pays?
Great question. So our platform is freely accessible to all pharmacy professionals. There's no charge to download and use the app. Our business model involves partnerships with commercial manufacturers and distributors, as well as global health partners who want to scale engagement with retail pharmacies across the 6 countries where we work. So we partner with global health partners and industry partners, and as a result, we are not charging any fee to our users.
Mm-hmm. Okay, thank you, Jos. There are more questions, of course. I will come back to you. Okay, it's time to entertain more questions. So I will request the audience to put more questions for the presenters. Few of the questions we jump from the previous presentations. It's for Dr. Tabita. Have you determined why men have higher initiation and continuation rate than women? Dr. Tabita, over to you.
Thank you. Yeah, so from our qualitative interviews, we did learn that a lot of the men would refer their friends to the pharmacies, which is why we saw higher initiation rates among the men than the women. And I can see Dr. Were, who is one of the researchers we worked with in this study, he also added that for men, because a lot of them work during the day, accessing PrEP through these pharmacies was much easier for them because pharmacies were open for longer hours as opposed to public clinics, which would be closed by the time they would leave work. Additionally, due to the referral and the convenience of these pharmacies, the men could just walk in at any time and initiate PrEP. I hope that answers the question.
Okay, thank you. Okay, maybe one more question for Jocelyn. Are there insights or lessons from non-RH service areas? What are the similarities and differences? And which health area are pharmacists most likely to be interested?
That's a great question. Thank you so much for asking that. At SwiperX, our content is not focused on reproductive health or HIV. Our content spans a number of health areas, and we work very closely with our users and key opinion leaders, as well as with the ministries of health and pharmacy regulatory authorities to make sure that our content meets the needs and preferences of retail pharmacies in each market where we work. So it's quite broad, it's quite diverse. If you were to ask me, what is the preferred content, that's a really tough question to answer because it changes, right? If there's pharmacy professionals by nature as community health providers are reactive and responsive to the needs in their community. So when there is a dengue outbreak or when it's flu season, right, we see a peak in requests for information that correspond to those, seasonal changes. But I think generally we're seeing across Southeast Asia increasing focus on NCDs, right? Retail pharmacies are serving so many clients with diabetes, hypertension, and other cardiovascular disease risks, that equipping them more and better with the information, the skills, and the tools that they need to serve those clients, as well as clients who need reproductive health services, is really, really important. Over.
Thank you, Jos. Maybe one question, I can send it to Dr. Tabitha. In the pharmacy sphere, how common is it for private pharmacies to dispense medications or products that are free in other channels? Like some of these self-care products, they are given for free in public sectors, like governmental sectors. So how do you see it? If you get anything from your studies?
Yeah, so actually, one of the advantages of using pharmacies to deliver some of these services is that, number one, there is assured privacy because it's just you and the pharmacy provider. There is also the ease of accessibility, as we've said. And so we do find that a lot of individuals prefer to go to private pharmacies than public facilities. If we take the example of people who work during the day and an 8-to-5 job, that would mean that they would never find the public facilities open, especially in Kenya, because they're open from 8 a.m. to 4 p.m. And so if you need any services, it would then make much more sense to get them from the private pharmacies. Another thing is that public facilities are far and spaced. And so it is much easier to just go out to your community pharmacy or your local pharmacy and get this service as compared to traveling to the public facility in order to get this service. So it is common for individuals to pay for services that would otherwise be offered for free at public facilities.
Okay, thank you, Dr. Tabitha. If there are more questions, we can entertain. Otherwise, I think these are the questions so far dropped on the chat box. Any more questions from the audience? Okay. It's for Jocelyn. Regarding NCDs is on the rise. Pharmacists have to choose, especially if they are close to capacity, as to which service areas are easy to provide, ensure good revenue flows, easy to stock products movement, and such. So do you have anything to add, like here, Jocelyn?
I think that that's a really valid comment. Thanks so much for that. I think it's important to recognize, as we all do, that pharmacy professionals are businesswomen and men, as well as healthcare providers, and so certainly, the business potential and elements are aspects of their decisions, whether it comes to stocking decisions, merchandising decisions, dispensing and counseling. But I think we've also found that, just as we have with other cadres of health providers, that behavior change is possible with skill building, with nudges, right? With solutions that address structural barriers. And in this case, that includes, in particular, helping retail pharmacists access the best quality products for the best prices, delivery terms, for less time, right? I mean, I think in a lot of the markets where we work, the supply chains are so inefficient that we find retail pharmacists in our network are spending so much time sourcing product, right? And they're not even at the end of the day necessarily getting quality assured products for the best price. So, addressing those supply chain barriers is really critical to empowering them and enabling them to do their best work as self-care facilitators and as community health providers.
Okay, thank you, Jocelyn. Okay, maybe for Tabitha. I'm really struck by the increase in initiation in your phase 2 trial. What are your theories of why this increased so much?
Sorry, could you please come again?
I am really struck by the increase in initiation in your phase 2 trial. What are your theories or why this increased so much?
Yeah, thank you. One of the theories is that the scrapping of the cost of initiating this service in the extension phase must have positively impacted the initiation of PrEP at these private pharmacies. A second thing that we did note was that in the original pilot study, some of the individuals who came to initiate PrEP were actually PEP clients, to mean that they had already been exposed. And so we did see that PEP could be introduced into the pharmacies as a gateway or as a bridge to using PrEP. And so this could also be another theory as to why the initiation in the extension study increased. And lastly, the provision of STI testing in these pharmacies encouraged more clients to initiate PrEP at the pharmacies. Thank you.
Thank you, Dr. Tabitha. I think we are finished the questions. Okay, let me give the presenters, if they have if you guys have something to say or any message, any remaining message for the audiences. Rusha, Jocelyn, Dr. Tabitha. Do you have anything to say?
I would just thank everyone for making time and joining us. It's wonderful to see so many other pharmacy champions, and it's important for us to keep this this sub community of practice going and growing. So thank you so much.
Okay, thank you for your presentations. for the audiences, we are gonna drop a link just to collect your feedbacks. So please be free to give your genuine feedbacks on the link below. From all the three presentations, we have learned that how it's very important to expand the accessibility of self-care products and services via private pharmacies. Of course, there should be follow-ups by regulatory bodies and different stakeholders just to assure the quality of services given in the sector, because our ultimate goal is just for the clients to get quality services and products whenever they demand it. So we are coming to the end of this session, and I would like to thank all the presenters, participants, and session organizers for being part of this session. Thank you very much.
Thank you.
Thank you.